Hello, this is Dr. Sanam Logavi from MD Anderson Cancer Center in Houston, Texas. Welcome to Secondary AML Through the Microscope, a pathology-informed guide to modern diagnostic and treatment principles. In a few moments, we'll take a trip together through the microscope to explore one of the more challenging and historically difficult to treat subtypes of acute myeloid leukemia that we refer to as secondary AML. The good news is that now we have modern tools for accurate diagnostic assessment, as well as therapies that are more effective than the conventional chemotherapy options we used in the past. We'll start with some basic but important definitions. What is secondary AML? How do we classify it? And what are its relevant molecular features? So with that, let's go through the microscope to find out. Secondary AML, by definition, is a form of acute myeloid leukemia arising either from an antecedent chronic myeloid neoplasm, such as myelodysplastic syndrome or myelodysplastic syndrome myeloproliferative neoplasms, which we also refer to as acute myeloid leukemia with myelodysplasia-related changes, or an acute myeloid leukemia that arises in the setting of prior cytotoxic chemotherapy and or radiation therapy in patients that have been treated for other conditions. And this form of AML is called therapy-related acute myeloid leukemia, which is another form of secondary AML. Collectively, secondary AML comprises about 25 to 35% of all acute myeloid leukemia cases, as shown on this bar graph here. The World Health Organization defines therapy-related AML, or what you'll see we will refer to as T-AML for the rest of this presentation, as an acute myeloid leukemia that arises from prior cytotoxic therapy or ionizing radiation therapy for an unrelated disease or a previous cancer. The prior malignancies that are associated with therapy-related AML are various tumors. They range from solid cancers to lymphoproliferative disorders. Some patients get treated for rheumatoid arthritis or other autoimmune conditions. Patients that are treated for plasma cell myeloma or multiple myeloma or acute lymphoblastic leukemia. So the classification of AML is complex. We classify AML based on various settings that can be clinical or the genetic composition of the disease. We'll start from the inner circle here. There are acute myeloid leukemia cases that arise in patients with Down syndrome. And so those are called acute myeloid leukemias associated with Down syndrome. If there's a history of prior cytotoxic therapy, like we just talked about, then that is classified as a therapy-related AML. Some acute myeloid leukemias have recurrent cytogenetic abnormalities, and these are referred to as acute myeloid leukemias with recurrent genetic abnormalities. If the patient has a prior history of myelodysplastic syndrome, or if the acute myeloid leukemia has specific cytogenetic or genetic changes that are associated with dysplasia, then that acute myeloid leukemia is referred to as AML with myelodysplasia-related changes, which is the topic of this discussion today. And then there are cases that don't fit into any of these specific boxes, and those are referred to as AML not otherwise specified. And obviously there are other types of AML that are classified specifically as well, but are not included here, but we're going to keep it simple for the sake of this presentation. The World Health Organization defines acute myeloid leukemia with myelodysplasia-related changes as an AML, which by definition has equal to or more than 20% blasts in the peripheral blood or the bone marrow, but it also needs to meet one of the following criteria. So the patient needs to have either a history of an antecedent chronic myeloid neoplasm, which most commonly is myelodysplastic syndrome, but it can also be myelodysplastic syndrome myeloproliferative neoplasm, such as chronic myelomonocytic leukemia, for example, or the AML needs to have one of the following. So either there needs to be cytogenetic abnormalities that are myelodysplasia defining. And these are the ones that we've listed here on the presentation for you. These are, commonly involve deletions of chromosome 7 or the long arm of chromosome 7, deletions of chromosome 5 or the long arm of chromosome 5, isochromosome 17q, and the other ones that are included in detailed here. There are also specific balanced chromosomal translocations that define myelodysplasia-related cytogenetic abnormalities. And then also, one of the common abnormalities that we encounter in this setting is having a complex karyotype, which means that the neoplastic cells have 3 or more cytogenetic abnormalities. And then the final or last category is actually something that is morphologically defined. So it's something that we assess using the microscope. And this is the presence of morphologic dysplasia in more than 50% of cells in at least 2 myeloid cell lines. And what we refer to as myeloid cell lines includes the megakaryocytes, the erythrocytes or erythroid progenitors, and the myeloid cells or granulocytic progenitors. Now, there is one caveat to this criterion, and that is that it cannot be in the setting of an NPM1 mutated or a biallelic CEBPA mutated AML, because those types of AML will often have morphologic dysplasia that does not have the same prognostic implications. So those two are specifically excluded from this criterion. Now that we know the defining features of secondary AML, let's take a look at some of the diagnostic tools that we have that we can use to help capture this high-risk subtype of disease. So as you know, traditionally, a diagnostic workup for a myeloid neoplasm or acute myeloid leukemia or any bone marrow-based neoplasm includes morphologic assessment of the bone marrow, which in our hands in our lab is usually done on the same day. We have various cytochemical stains that we can use to assess various cell lineages. Again, this can be done rapidly with inexpensive methods, and it can be done on the same day. We use flow cytometry to assess the immunophenotype of various cell lines in the bone marrow. The turnaround time for a complete flow cytometric assessment in most laboratories is probably about 1 day. And then we look at the genetic makeup of the cells in the bone marrow using 2 methods. One is conventional cytogenetics or a routine karyotype, which usually takes about 3 to 8 days to get back. And then also within the cytogenetics lab or within the cytogenetics pipeline, we are able to evaluate the sample using fluorescence in situ hybridization or FISH. And the FISH panel that we do is variable depending on the suspected diagnosis, and it can vary from institution to institution. But normally for a newly diagnosed AML, we will assess for PML-RARA, which is the defining cytogenetic abnormality for acute promyelocytic leukemia. We investigate the presence of translocation 821 or inversion 16, which are the defining features for the core binding factor leukemias. If there's a suspicion for BCR-ABL fusion, we're able to do a rapid BCR-ABL fusion test using FISH. And then additional FISH can be done based on, again, the diagnostic features that we see based on morphology. And then also another method to look at the genetic makeup of the acute myeloid leukemia is actually a constellation of methods, is molecular assessment. And that includes either single gene sequencing tests or next generation sequencing, which is assessing for several mutations at the same time. NGS panels typically in our hands take between 3 to 5 days, and that's the turnaround time, but it can vary from institution to institution, and sometimes they can take up to 14 days to get the results of the full panel back. So we talked about morphologic dysplasia being one of the defining features of acute myeloid leukemia with myelodysplasia-related changes. So what do we mean by morphologic dysplasia? Here is a presentation showing various forms of dysplasia in the megakaryocytic series in various cases of myelodysplastic syndrome. So this can manifest as the megakaryocytes being small and hypolobated. It can manifest as separation of the nuclear lobules of the megakaryocytes, and increased nuclear to cytoplasmic ratio, or just nuclear hyperchromasia. Erythroid dysplasia can manifest also in various forms. There are examples shown here. This picture here shows pycnosis, which is a form of dysplasia. Multinucleation can be seen as a result of myeloid neoplasms, again manifesting as erythroid dysplasia. This is an example of binucleation, which is a form of dysplasia. Megaloblastoid or asynchronous maturation can be a feature. Nuclear fragmentation can be seen as a form of dysplasia, as can nuclear budding. And then basophilic stippling of cytoplasm is a feature of dysplasia, as is cytoplasmic fraying, which is this irregularity on the edge of the cytoplasm of this erythroid precursor. So we talked about morphologic features, but what are some of the other diagnostic features or genetic features of acute myeloid leukemia with myelodysplasia-related changes? This is a study that was recently published where the investigators looked at a series of secondary AMLs, which included acute myeloid leukemia with myelodysplasia-related changes that was diagnosed based on an antecedent history of a chronic myeloid neoplasm, and that's indicated with an H here. AML MRC that was diagnosed based on cytogenetic abnormalities, indicated with a C here. AML MRC that was diagnosed based on morphologic dysplasia, indicated by an M here. And then acute myeloid leukemia with myelodysplasia-related changes in the setting of previous therapy with cytotoxic agents. And as you can see, these are the frequencies of mutations in these various categories. And one thing that stands out here, and that was significantly different, is that in the group with acute myeloid dysplasia-related changes that was defined by the chromosomal abnormalities or the cytogenetic abnormalities, these cases more often had mutations in TP53, and that actually makes sense because, as you know, TP53 mutations are more often associated with a complex karyotype, so you would see that difference there. And then you can see the different frequencies of various mutations in the different groups, which is pretty much similar between the four categories. And this is another representation of showing the mutational landscape in these various groups. So on the top here, the purple bar is the acute myeloid leukemia MRC diagnosed by morphology. Orange here represents the cases that were diagnosed based on cytogenetic or chromosomal abnormalities. Green is based on history, and red are the cases or the patients that had received prior cytotoxic therapy. Each of these columns here is one individual case, and the genes are listed on the left-hand side, and these are the frequencies of the mutations. And so the most common mutations based on this assessment were U2AF1 and SRSF2, which is a splicing factor, and followed by the various different categories. And here you can see them grouped by their functional significance of the various genes. The genetic makeup between the four groups is similar, except for you can see that the frequency of TP53 mutations is much more higher in the group defined by cytogenetic abnormalities because there's an increased representation of cases with complex karyotype in this group. Okay, so we've looked at some of the key features of secondary AML and some of the tools that we can use to help us make this diagnosis accurately. But what about prognosis? What does it mean for patients when they have a confirmed case of a secondary AML, which includes therapy-related AML or acute myeloid leukemia with myelodysplasia-related changes? There have been several studies published in the literature, and this is one such example showing that older patients with secondary AML have a worse prognosis with a shorter overall survival compared to patients in the same age group that present with de novo disease, as shown on this Kaplan-Meier curve. So here you can see that patients with de novo AML had a longer overall survival compared to the patients that had secondary AML arising from an antecedent myelodysplastic syndrome, secondary AML arising from chronic myeloid neoplasms other than MDS, including myelodysplastic syndrome, myeloproliferative neoplasms like chronic myelomonocytic leukemia, or myeloproliferative disorders. And this group is shown in the gray line here. And then the patients that had therapy-related AML. So combined, these patients in the secondary AML group had an inferior prognosis compared with patients that presented with de novo disease. And the poor prognosis remains the same in patients that are younger than 60 years of age as well, as shown on this curve here, where you can see that the patients with therapy-related AMS is shown by the red line, secondary AML non-MDS as shown by the gray line, and then secondary AML MDS as shown by the yellow line have inferior overall survival compared with patients that presented with de novo disease. Okay, to recap, we have the tools and the skills to make a diagnosis of secondary AML, and we know that it confers a poor prognosis. That said, in recent years, we have seen the emergence of several novel therapeutics, some of which have shown improved efficacy in high-risk settings, including therapy-related acute myeloid leukemia or acute myeloid leukemia with myelodysplasia-related changes. Let's take a look at a case to demonstrate this point and to demonstrate the diagnostic features that we reviewed, using our diagnostic tools to see how an accurate pathologic assessment can help inform the right treatment choices for our patients with acute myeloid leukemia. So to demonstrate this point, I'll present you with a patient example and show you how pathology testing and interpretation of results can inform selection of therapy in the setting of secondary AML. So Victoria is our patient. She's a 49-year-old woman with history of myelodysplastic syndrome. She was treated with 6 cycles of azacitidine, but unfortunately, her disease rapidly progressed and evolved into acute myeloid leukemia. She was treated with IV chemotherapy at another institution, the details of which are not known to us, but stopped therapy due to the development of adverse events. And at this point, her disease had not gone into remission. So she then received decitabine plus venetoclax, and after 2 cycles, she was advised to seek hospice care. At this point, she came to MD Anderson for a second opinion and wanted to know what the next steps are and whether there were additional treatment options that could be offered to her. So what are the next steps for us in terms of making an accurate diagnosis that can better inform the selection of appropriate therapeutic options for our patient? This is her bone marrow biopsy. On the left side is a low-power image showing that her bone marrow is hypercellular for age. Megakaryocytes are increased here. They have an abnormal distribution because they're forming loose clusters. And then they also include these small hypolobated forms that have high NC ratio. This one here in the middle is very hyperchromatic. And so the megakaryocytes are dysplastic. This is a higher power image, again, showing the megakaryocytes here that are dysplastic, a decreased myeloid to erythroid ratio, as well as increased immature cells that are mononuclear. They have open chromatin and prominent nucleoli, suggesting that they are immature cells and blasts. Next is various images from her bone marrow aspirate smear. On a lower power image, I wanted to demonstrate the megakaryocytic dysplasia for you here. You have the small hypolobated megakaryocytes, and then there are increased blasts. This cell is a blast with increased NC ratio, a immature nuclear chromatin, a prominent nucleolus, and then small cytoplasmic vacuoles and very little cytoplasm. And then you also have erythroid dysplasia in the background, as shown by this nuclear fragmentation in this cell, and then the asynchronous maturation that is present in the erythroid precursors. Here you have another blast on this edge here. There are a couple of blasts here. And then this erythroid precursor is also dysplastic because it has this cytoplasmic fraying that we talked about. Here's another dysplastic erythroid cell that has nuclear contour irregularity. And then the myeloid cells are also dysplastic. This is a hypolobated granulocyte that is also hypogranular. So there's trilineage or multilineage dysplasia here. And we also did an iron stain in this case that showed the presence of increased ring sideroblasts. So we talked about the genetic makeup of acute myeloid leukemia and the frequency of various mutations in the setting of AML MRC. So we did next-generation sequencing on this patient's bone marrow that showed the presence of IDH1 as well as a TP53 mutation. And the cytogenetic workup showed a complex karyotype. And as we said, a complex karyotype in and of itself is a defining feature of acute myeloid leukemia with myelodysplasia-related changes, but I also want to bring your attention to the details of this karyotype. So this complex karyotype includes abnormalities of chromosome 5 and chromosome 7, as well as chromosome 17, which we said is a feature of myelodysplasia as well. Okay, so let's go back to our diagnostic criteria for acute myeloid leukemia with myelodysplasia-related changes and see whether or not this case fulfills these criteria. So the patient does have a history of MDS, as we mentioned. This case has a complex karyotype, including several of these abnormalities that are listed here, and we did document the presence of morphologic dysplasia in all 3 cell lineages. So essentially, we can get to AML MRC for this case from any of these 3 routes, but basically all 3 of them are present. Okay, so now that we've confirmed the diagnosis of acute myeloid leukemia with myelodysplasia-related changes for our patient, what are some of the treatment options that we can consider for this case of secondary AML? So CPX-351 is a liposomal formulation of cytarabine and daunorubicin. It was approved by the FDA in 2017 for adults with newly diagnosed therapy-related AML or acute myeloid leukemia with myelodysplasia-related changes, and more recently in 2021 in the pediatric patient population that are aged 1 year or older. In a major randomized phase 3 clinical trial, CPX-351 was tested against the conventional 7+3 chemotherapy regimen in older patients with high-risk or secondary AML. The key eligibility criteria for this trial included previously untreated disease. They included patients aged between 60 to 75 years of age that were able to tolerate intensive therapy and had a performance status of 0 to 2. One arm of the trial got CPX-351 and the other arm got the conventional 7+3 regimen. And they were further stratified based on therapy-related disease, AML with history of MDS, with or without prior HMA or hypomethylating agent therapy, AML with history of chronic myelomonocytic leukemia, de novo AML with myelodysplasia-defining karyotypes, and then the patients were also stratified into 2 age groups, those that were between 60 to 69 and those between 70 to 75. So after a 5-year follow-up period, CPX-351 showed consistently improved overall survival versus the conventional 7+3 regimen in the overall population study, regardless of age. And this Kaplan-Meier curve here shows the survival percentage of the 2 groups. The blue line represents the patients treated with CPX-351, and the orange line represents the patients treated with 7+3. And you can see that the overall survival was improved in the CPX-351 group. These substantial benefits appeared to be even more pronounced in patients who went on to receive hematopoietic stem cell transplantation, as shown on this Kaplan-Meier curve here. However, the patients treated with CPX-351 had prolonged neutropenia and thrombocytopenia with a median of 30 to 35 days after cycle 1. So venetoclax is another highly active therapeutic option for patients with acute myeloid leukemia. And in the VIALE-A trial, they compared patients receiving azacitidine alone with patients receiving azacitidine plus venetoclax. And as you can see, the addition of venetoclax improved the probability of overall survival in the patients treated on this arm as compared to the patients that received azacitidine plus placebo, which are the ones shown in the orange line here. This trial included therapy-related AML, patients with acute myeloid leukemia with antecedent MDS that were previously untreated, acute myeloid leukemia with myelodysplasia-related changes, although patients with treated MDS and myeloproliferative neoplasms transferred to AML were not included. So venetoclax, in combination with azacitidine or decitabine, was also tested in a smaller study of 145 patients with a median age of 74 years that included patients with secondary AML. And in this study, 51% of the acute myeloid leukemia cases had intermediate risk cytogenetics, 49% had poor-risk cytogenetics, and 25% had secondary AML. And in this study, patients with poor-risk cytogenetics and those at least 75 years old had a composite remission rate, which includes complete remission and complete remission with incomplete recovery of counts, rate of 60 and 65% respectively. So let's go back to our patient. After assessment and a thorough diagnostic workup, it was deemed that she had acute myeloid leukemia with myelodysplasia-related changes. We characterized the morphology, the karyotype, and the mutation profile. So based on these findings, CPX-351 and ivosidenib, which is an IDH1 inhibitor, were offered to her in the setting of a clinical trial. Her disease went into remission. She remains MRD positive and is awaiting allogeneic hematopoietic stem cell transplant at this point. We're almost done with our diagnostic journey, but before we conclude, let's put everything together and synthesize how a comprehensive assessment can help pathologists and hemato-oncologists collaborate when managing patients with this challenging AML subtype. So as we said, we have various tools in our diagnostic armamentarium. This includes morphology or morphologic assessment to assess for dysplasia. We have specific cytogenetic changes that are associated with this subtype of disease, including recurrent chromosomal deletions, the presence of complex karyotype, or some of the previously defined balanced translocations. Flow cytometry is another tool that helps us determine lineage. It doesn't necessarily help clinch the diagnosis of secondary AML, but obviously it helps confirm the lineage of the neoplastic cells, which in this case should be myeloid. And then we have molecular tools to assess for the presence of somatic mutations. And as we said, TP53 mutations are very common in secondary AML, which includes acute myeloid leukemia with myelodysplasia-related changes, as well as the therapy-related forms of disease. So pathologists and oncologists need to work collaboratively and together to ensure that appropriate information is captured and that an accurate diagnosis is made so that appropriate therapy can be selected for patients with secondary AML with hopes of improving ultimate outcome. So ideally, we should communicate the results of our pathology testing and confirm the diagnosis. This can be therapy-related acute myeloid leukemia based on the history of receiving cytotoxic chemotherapy or radiation therapy, or it can be based on an antecedent history of a chronic myeloid neoplasm, or again, as we said, the presence of morphologic dysplasia or myelodysplasia defining cytogenetic changes. And with that, the oncologist can make an informed evidence-based therapy recommendation. Currently, the NCCN guidelines recommend CPX-351 as a Category 1 therapy for patients older than 60 years of age, standard dose cytarabine regimens or CPX-351 in patients less than 60 or younger than 60 years of age. To date, evidence suggests that venetoclax-based treatments may also be active in this disease subtype. That concludes our microscope-aided journey through the biology, diagnostic assessment, and management of secondary AML. I hope you found this program interesting and useful for your practice, and thank you for joining me.
This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education.